And you have slides too?
I do, yeah.
Okay.
Let me just practice sharing. I can see them all. Okay.
Hey, welcome everybody. Oh, Carol, it's nice to see Carol. I see your face anyway with it. And Tim. So thank you everybody for joining us today. And we're going to have a couple slides first. We're going to just show, or should we maybe do introductions first? And anyway, we are very excited today to have one of our own, Tim Cowan, whom I think if you don't know him, you should know him. So it's good, but it's truly a pleasure to introduce Tim. He serves as a director of surveillance, evaluation, and assessment at MaineHealth, so also known as SCA. And he's one of those rare public health leaders who understands that data are not only powerful when they are connected to people, that they are only powerful. Data are only powerful when they're connected to people, communities, and real-world decision-making. And indeed, he and his team, who many of here I think are on the call today, do help us make very excellent decisions related to people, communities, and all kinds of related issues. Tim is trained as an epidemiologist. He earned his MPH with a focus in epidemiology, and he has spent more than 3 decades helping Maine understand its health challenges, and just as importantly, helping us to act on what data tells us to do. His work has spanned tobacco prevention, chronic disease, suicide prevention, and community health assessment, always with a focus on turning numbers into insight and insight into changes. So across MaineHealth and in partnership with public health and community organizations, Tim has also shaped how we use shared data to guide priorities, strengthen collaboration, and advance more equitable outcomes, especially in our rural communities that face quite a few of these challenges. And Tim, you have to remind me, you've been at MaineHealth for how long?
Second stint since January of 2009. And I was here about 5 years prior to that.
Oh my gosh. So you've been here then
a long time, almost 20 years.
Almost 20, about 20 years. And before that, you were at the Maine Primary Care Association? No. MaineHealth Access, MaineHealth Assessment Foundation.
You got it. Maine Medical Assessment Foundation.
Maine Medical Assessment Foundation.
Moved to Maine for that job, and then moved to core at MaineHealth for almost 5 years, and then went to Health Dialogue for 2.5 years, and came back to the right side of the world. Joined
Maine. We're very fortunate to have you. I have always just so enjoyed working with you these last 7 or 8 years, and before that. So today, Tim is going to also introduce us to some new public health data sets that are out there. There are new ones evolving as we speak. So I suspect we may have to have you come back in a few months to give us an update. So I'm going to pass the baton to you. Thank you so much, Tim, for joining us, and thanks everybody else. And
absolutely.
And then, Alan, you've got a couple slides there, I think, too.
Exactly. I'm standing between the
jump in,
presentation.
Alan.
So just want to make sure if people want CMEs, the code is here. I'll put this in the chat. And this is some instructions if you need support in accessing the cloud CME, and also the statement that none of the planners, faculty, or others have any financial relationships to gain from this presentation. And we are excited to have Tim, so I'm going to stop sharing now, and you can take it away. We were
also going to do the flyer for the next
Yes,
round.
I'm going to put that next on March 10th. We have Dr. Dave Chowsky, who's coming to speak. He's Coalition for Public Health, and is that the name of the organization? I will put that in the chat.
Common Health Coalition, and then Joey Roden, who oversees DEI, basically, or formerly known as DEI, for the American Hospital Association, and then that's April 28th. So hopefully you'll put that the information in the chat. And then Michael Osterholm, who's internationally known on infectious diseases, communicator about them. He's coming on May 12th. So hope you all can join us then as well. All those things. Thank you. Thank you, Tim. Take it away.
let's try that again. Thank you all for joining and taking up your lunch to explore data with me and your colleagues. So I'm gonna kind of be jumping back and forth a little bit here. Can people see the slides? And Ellen, can you see that?
Yes.
Yes.
Okay. So these are the four. We only have an hour, and I want to leave some time for questions, comments. So I'm being ambitious. I'm going to try to run through quickly four different kind of data sets or systems, websites that you guys all can explore afterwards. And I put in the links here so that when we send out the slides, you have them available to you. So the first one I'm going to go to is the Population Health Information and Visualization Exchange, and I'm just going to swap over to here. So it's okay, get out of the way. There we go. Okay, so Population Health Information and Visualization Exchange, otherwise known as PopHIVE. It's out of the Yale School for Public Health. This is a really quite new website and growing number of dashboards. I want to emphasize it's a growing number of dashboards. You'll see here that they're kind of continuing to work on different topics. These top four, the four dashboards that they have right now, and they're working on youth well-being, and then more to come after that. I'm going to give you just a few examples, but the thing that I really like about PopHIVE is that they're striving to pull data, different types of data, like clinical data from Epic Cosmos, which is electronic medical record data that's available, combined and de-identified and combined nationally, with our more traditional public health data sets. And they then kind of are truly going through a process to assess the data and identify what that story is, how to make that, highlight those insights, as Dora mentioned, what actions can be taken. So I encourage you to kind of check this out on a periodic basis, because I think there's going to be more and more here. Again, I'm just going to do a couple examples. Childhood immunizations, I'm not going to go into. It's a lot of really good data from National Immunization Survey and Maine Kids, school kids data. So that's it. They've done a really nice job of processing that. So I encourage you to look at that. This is one I just wanted to highlight. This is an example, I think, one of probably several chronic disease type of data that they're going to publish over time. This is looking at data for diabetes and obesity, and from different data sets and in different angles, different perceptions, lenses. So just one thing to highlight, it's a very user-friendly data set. There's a how to use this data on every dashboard that they've created. It's really well laid out. In this case, you'll see that there's Epic data from electronic medical records. MaineHealth does contribute to Epic Cosmos, by the way. And the importance of that is for something like diabetes, they're looking at laboratory data or data of a diagnosis of diabetes in the medical record. And we can look at that, and you can then compare contrast to self-reported data, which is from the Maine CDC, the Behavioral Risk Factor Surveillance Survey, and then another comparison of Medicare fee-for-service. So that's really, that's the key thing with PopHIVE. It's really, really great. And it's very easy to use. In this case, they have a state map with at the state level. We can also look at the county level. But this gives you, so this is Epic data, rates based on Epic records. And then this is self-reported from Burfus, pretty similar. This is a lot darker when you look at the diabetes. Well, that's because this is 65 plus. So you can go here and you can look at age by age group, and you can go back and forth. The other cool thing is that for Medicare, fee for service, and for Epic, they have data at the county level. And so we can go here and select, let's look at Maine. And in this case, if we were to look at these patterns, let's see if I can shrink this a little to get the, okay, there's the legend. So here, this is looking at electronic medical record data. All right, so this would suggest that rates are highest in York County, Oxford County, Franklin County, and Aroostook County. There's an important piece here, though, that if you look at this pop-up that's going mad all over the screen, you'll see 18% diabetes prevalence. You'll also see that 76% of the population in York is represented, meaning they're taking the total population and they're saying, well, how many people do we have Epic records for, right? And they're getting an estimate. It's pretty high in York. It's pretty high up in Oxford, and this is again 65 plus, so it's really high. It's over 100% in Franklin, so, meaning they've seen more than the number of 65-year-olds who live in Franklin who have a medical record. It's not so high up in Aroostook. And if we go to where, Washington County looks really healthy here. They only have 18% of our medical records. I'm pointing all this out because if you switch over to the Medicare fee-for-service, the map changes completely, right? Franklin is still around 18% because they have saturated with medical record. It's 28% in Aroostook in Washington. So this gives us a way to look at different lenses, right? There's advantage of the medical record with Epic, and this is fee for service. There are some advantages, disadvantages. We have a high prevalence, high saturation of Medicare Advantage plans. So fee for service is somewhat limited, but it gives us an important different lens. So that's just, some ways to look at it and think through it. If we go back, I wanted to also go to injury and overdose. This is important. Let's see if we can, because this is a big focus, certainly in Maine. A lot of this is overdoses, is overdose deaths. So with the opioid epidemic and we've seen very, very high rates. But again, they're trying to combine data from different places. In this case, the graph on the left is death data from two different sources, both managed by the CDC. One is the National Center for Health Statistics. This should say NCHS. It does correctly down here. WISCARS is injury data database. This is ED visits from our Epic records. And then this is Google Trends searching for Narcan. So it's kind of, it all tracks. And so you can kind of look at different sources of data. So also with this, I wanted to jump down to the trends by age, just to highlight some. Here they have ED visits, and then they have death data. And the nice thing is that if you get your eyes blur with too many lines, you can select them out. And so let's look at just 65-year-olds in the total. You'll see that the death rates have gone up over time, but our ED visits for those groups have not. Maybe there's an intervention opportunity there, right? Right. Maybe we're not identifying people or not able to get to them. Maybe these are people who are isolated, living alone, that type of thing, and just have a problem with that. So I think what they're doing here is really, really great. The other thing too, this is just an example. They've set this up so we can look at overdose changes and overdose deaths by state over time. And you kind of see that pattern that's happening. This is ED visits. And then if we go to deaths, you can kind of going way back to 2015 for the past, you can kind of see where it started. It started in the Appalachia areas here, West Virginia, Ohio, Pennsylvania, Kentucky. East Coast got hit hard more earlier than the rest of the country, and then it's kind of spread across. So interesting, perhaps, for someone to be able to look at how can we share lessons learned. I will say that I'm not going to go into it because we don't have the time, but there's some really fun trends over time mapping tool with the respiratory diseases. So they have influenza and pneumococcal, and for example, they have data at the county level. And so you can look at the percent of ED visits over time by week at the county. So it's kind of really cool. You can kind of go through it and you can see influenza and where it spikes and how it spreads across the country. And so I'm a chronic disease epidemiologist, so I wouldn't be able to provide you the insights there. Maybe one of our future presenters who's an infectious expert in infectious disease could, talk about that. But, again, this is where, I think there's going to be more and more coming out, and there's some really great work happening by colleagues down at Yale School of Public Health. Second, I want to go to places. So folks are familiar, I believe many of you are familiar with the Behavioral Risk Factor Surveillance Survey. That's a system, the national system. It's the longest lasting kind of surveillance tool survey process we have in the country. And it's federally funded, and then in part by states supplement funding. And every year they're asking questions about people's health status and health risk behaviors or protective factors. And they get, until now, we've been having, the data we had was for state rates. And for the full surveys, that's where it still is. You can go and you can pull that data down, you can do analyses. What Places has done with behavioral risk factor surveillance survey data is that they've created an interactive mapping, interactive portal kind of with the maps, and they're going to the sub-county level. And so we'll look at the county and then the sub-county level, and we can look at that. I just wanted to highlight the data portal. I'm not going to spend any time on it other than to say, if you really love to dig in and you want to do research, I encourage you to look there. There's a lot of different places. They've connected data that are surveys that are run by the national, by institutes of health, or with death data. There's lots of really cool things in there. And then finally, the comparison. I mentioned that this takes data for a set of behavioral risk factor surveillance survey data questions to the county level. This comparison report, you can select up to 3 counties across the country, and it will run a report and compare them, the data, the output for all 40 measures and RIFs and 9 additional. So I'm just going to very quickly highlight the measures, the definitions. It's important. If you want to understand kind of what those questions are, for example, the arthritis data that we'll look at in a moment, it's a question that says, have you ever been told by a doctor or a health professional that you have some form of arthritis? And all of these measures are taking these questions that were at the state level, and they're applying regression modeling and approaches to create probabilities within sub-state levels. So let's get into the fun stuff. Let's look at the maps. I've already pulled this up a little bit. And so you'll see, I mentioned there are Places has selected 40 measures out of the many more than 40 measures that the surveillance system asks in each survey each year, and it's created maps and estimates for each of these 40, and they're in different categories. There's health outcomes, prevention, health risk behaviors. There's some disability questions that are asked in BRFIS data, and then there's some general health status. The health-related needs is an interesting subset. It kind of gets into some social needs challenges, and then there's 9 variables from the American Community Survey that they've included here, all in the same framework. They're calculating county and sub-county level rates. This particular map happens to look at arthritis. Again, that's have you ever been told you have some form of arthritis? So you can kind of look at these patterns, and if you stay at the national level, you can kind of see where things are similar or different. If we looked at obesity, here's the obesity rates across the country. Related to that, as we just saw on PopHIVE, is diabetes, and that's somewhat correlated. COPD, I think, is a valuable one, particularly for Maine, given we had a history of very high rates of smoking. Done phenomenal work there, but you'll see that the patterns are similar, but we have higher rates, and so this may be something that we can use this data for. So let's zoom in on Maine, and we can kind of look at that together. So here's the county rates, and if we keep zooming in, we're going to get to sub-county populations. So this looks at, it calculates estimates for county, for census tract, for what's called the zip code tabulation area, and then these dots in here are kind of reasonably sized towns, cities, and then they have the boundaries around them. So you can turn some of these things off if you wanted to just look at the tracks. You can do that. This adds in a little bit of a layer. So this is looking again at COPD, and if we roll way in and we put the places back, come on, there we go. So you're looking at boundaries, and the nice thing here is that we're no longer just looking at county level rates. We can look at within counties and the variability across those, where may be zip code areas, geographic areas that have higher rates. I believe this is Farmington. No, that's Turner. This is Farmington. Up here. So you can see that the COPD rates, the estimated rates, and they have crude rates just based on the sample they have for everyone in the county, and then they have age adjusted, so you can compare parts of Maine or parts of the country that we know are older than other parts of the country more fairly. So their age adjusted prevalence of COPD is around 8%. And if we go over to here, which I think that's Norway, it's 10%. Well, it's a significant difference. No, that's not one that was. Anyway, you can see these confidence intervals. For those who aren't data geeks like me, these are really important to look at with this data. Again, this is all survey data. And in every state, we're interviewing a sample of the population. We are not sampling all 1.3 million people or adults less than that in Maine. We're sampling closer to 10,000 people, and then we're making estimates for that. So the confidence intervals are important because there's a margin of error with any subpopulation. But that range, in this case, the estimate is 7.9%. The range is 6.9 to 9.1. That gives you 95% out of 100 samples. If we did 100 samples in Maine, the range would cover the true rate in the population. So it gives us a way to say, okay, where are areas that have significantly lower or higher rates? And what do we do to that? Well, hopefully we can then identify, well, where would we want to put our resources the most in terms of where there are higher rates. And, you can look at COPD, you could look at diabetes, and you can kind of get a sense of, okay, here's Norway, and the rate of diabetes is 11.3, and up here in Farmington, it's significantly lower. Or if we wanted to go at Livermore Falls is another place. So for our colleagues up in Franklin, this just probably reaffirms something that you likely know, but Livermore Falls has very high rates relative to the others in Farmington or others in that region for obesity, for tobacco, for diabetes. So perhaps that's where we put our resources when we're trying to work on these things. All right, so I wanted to look at just quickly health risk behaviors. I'm not going to look at all of them, but these are the 4 variables that are in there. So we have binge drinking and current smoking. Sorry, this mouse is very good. Here's current smoking. So for some of our work, our prevention work that we're doing, that can work really well. The prevention, speaking of prevention, these are questions that are asked and they're related to preventive care. And this, I'm just going to show you some patterns across the country because I think it's really kind of cool. Let's see if we can get this loaded here. So this is showing you, we open up the legend. This is the darker colors are the higher rates of percentage of people who don't have health insurance in their counties. So we do pretty well. And then, what's the correlation between that and annual checkups? I was looking at this and getting very excited because there's a colleague I have worked with in the city council and in Auburn, and whoops. I'm going to have to show him these maps because he doesn't quite understand that prevention, that we need insurance for prevention. It's not wanting to show me this, so let's see. There we go. All right. Colorectal cancer. So in other words, what I was going to show you, if it loads, is the patterns are pretty much opposite, and you would expect that. We are all in the healthcare, but it's kind of a nice visual aha moment for people who aren't as familiar with this to say there's a correlation here, guys. And you see a similar pattern with that in annual checkups and other things. All right, so we're at the bottom half of the hour, so I'm going to move on. I'm going to switch over to talk to you a little bit about Apriqot. Apriqot is, so I got to go to my slides. Bear with me here. All right, Ellen, can you see that? All right, perfect. All right, so Apriqot. I wanted to give you guys, if you're not aware of it, this is a local company. It was founded just a few years ago. It was part of, it was one of the members of the inaugural cohort of the Rue Institute's Future of Healthcare Founder Residency Program. MaineHealth, Northern Light Health, and Rue and many other organizations helped fund this program. It was started by 2 gentlemen, Ken Shapiro and Kevin Conti, who have been in public health for many, many years. One, Ken was a public health administrator. Kevin is a demographer, lives in New York, and has done a lot of sub-county analyses because he has to look at maybe 3 blocks combined in Manhattan or something like that. But so these guys were looking to find ways to get to sub-county data. So what they're doing is very, very similar to the places. It's a kin and spirit. But the projects that they've had thus far that I wanted to show you, some of, are taking it a little bit to the next level. They're combining information in a way to provide a new insight, or they're able to provide estimates, take models that exist and enhance them so that they're even more applicable to Maine in this case. So they started out, we worked with them the first time, MaineHealth, Center for Health Improvement, and the city of Portland. There was a grant we had, and we needed to know food security data at a sub-county level because Barbara Ginley was trying to figure out how to most effectively utilize her resources with the food pantry and an upcoming mobile unit for the food pantry in the greater Portland area. And we didn't have any data because the existing data we had was useful, but it was at the county level. So this is the first project they did, is that they took essentially two phases. The first thing was they built a model, and that they're using for all of their work. Essentially is taking American Community Survey, that's ACS, and they created a model at the household level. And so they created that for the state. And that's what they then applied and layered on food security data. The model they used for food insecurity was the same model that is used by Feeding America, which is a very popular model. It's used widely and has county level rates. It's good sound data. And they essentially used that, replicated it, but then were able to apply it to this population model to get sub-county level estimates. They added a few extra enhancements that worked. It strengthened the model in Maine, but for the most part, that they replicated that. And that's where this map here shows us data on household food insecurity at the census tract level. This is just quickly to give you a sample, a visualization comparison. This is the estimates they had in Feeding America. Feeding America was looking at estimates at the county level for all 3,000 plus counties in the nation. So the ranges, you don't have a lot of difference in most of Maine, but we're seeing a tremendous difference when we start looking at our census data. In this case, this is block group. But, it identifies pockets, including way down here in Portland, there are pockets, right? So it's giving us valuable information to move forward. The other cool thing with how they've built this model, in particular the population model and the infrastructure, is it's set up in such a way that additional data could be built in. They could build it into the models as we move forward if we wanted to. So, for example, started talking to them about potentially taking some of our food insecurity screening data and seeing if that would help enhance their estimates. So the health system data, again, the clinical data might be able to be applied to that. So that's an exciting thing that's moving forward with that. Another project that they did, this was done on behalf of the state. So the state has cancer screening programs, and it certainly covers those who are in uninsured or on Maine Care Medicaid. But what they wanted to look at was, okay, there are also people who may have insurance and don't know that they're eligible to get screening through the state program, and they wanted to identify the underinsured. So Apriqot created the first statewide estimates of underinsured individuals. And this is the algorithm here on the right that they used. So you either, if you don't have health insurance, you're uninsured. If you have some type of health insurance, if it's public health insurance, but you answered yes in the behavioral risk factor surveillance survey that you delayed seeking care because of costs or lack continuous health insurance, you were underinsured. And so these different algorithms, so they created this class that we didn't have before. We had uninsured, we had insured. So these are some of the results. So first, here's the map, sub-county level. On the left here, this is insured, patterned by insured. And then this is uninsured. And in general, overall, the patterns are kind of in contrast to each other, right? You see some areas are really low in insured rates and they're really high uninsured. Well, if we then add in the underinsured, it gives us an important third layer, but it also starts parsing out those regions where we really didn't understand that they may have had a pretty decent level of insurance rate. So for example, here, these two darkened areas, this one right here, that's Norway. This is South Paris. This is the Stevens Memorial region. Well, they're pretty high rates of insured, but there's a large number of uninsured. Another example, this is Portland. So the red circles on each of these maps and the arrows, that's pointing to Portland. Not a huge amount of uninsured, but it's a lower rate of insured, and it's really people that are underinsured, right? So here's an opportunity where, again, this is looking at the subdivision, they could go further down, but this is highlighting some of the challenges in a wealthy area, otherwise wealthy area, lots of resources, but also expensive. So it's just different ways to look at this. So, all right, so a third one that they did, this is exciting, particular for the health system. This is a project that Apriqot did again with funded with the state, the Maine CDC. There were in a similar story. We have data from national organizations that have county level estimates for Alzheimer's and related dementias. So it's looking at the prevalence of Alzheimer's and related dementias. This is incredibly important, obviously, for Maine being the oldest state in the nation. Maine CDC wanted to get sub-county estimates. So again, similar approach. Apriqot used the model that was already existing and then found ways to enhance it to make it even more applicable for Maine. In particular, they added in an education variable that really strengthened the model's accuracy. But they went through a process here. So this is giving you the estimates, the estimated prevalence of Alzheimer's and related dementias. Well, how could this potentially be used? Well, in one thing, it's being used by a researcher at MaineHealth in this grant here to expand and enhance this work. But it's intended to be used as a way to say, where are the hot spots in our service area where we might want to do be really focused on screening and identifying people earlier in the dementia process, because they do know clinically. And Peter Baker could probably correct me if I'm wrong here, but my understanding is that the earlier we identify someone with signs or early stages of dementia, the better the treatment, the more effective the treatment. And Peter, I don't know if you can add anything to that, but
sure. Oh, okay, sure. I just reinforce what you just said, that when we're able to identify people earlier, they're able to do more planning, they're able to have important conversations, they're able to really plan for future care needs and do things that they might not be able to if their disease was too advanced.
Awesome. Thanks, Peter. All right. So this again, that's one advantage. Another thing that we could potentially use this and some of the other maps is to look to see if we have these estimated prevalences, we could use our clinical data to say, okay, what are the diagnosis rates? Are we identifying people at the same rates that we would expect us to find them if these estimates are accurate? Are we not screening high enough, or are we not identifying or diagnosing in the same way? And we could look at that by stages, right? So, and again, the other thing that could potentially be done is that there may be clinical metrics that could be utilized, added to this work, either as an additional layer in the mapping or into the model. So really cool stuff there. I think I saw a note, someone couldn't find the maps. Yes, you're going to have to reach out to Ken Shapiro to get more information on these things and get the estimates. They'd be happy to share them. But this is very, very new. They've been working on, and they're just now kind of in the test phase, and would love people to test out a interactive mapping tool to be able to look at their data. So encourage you to reach out to Ken and to work through all of the, work through this, get permission to use the WHAM Wellness and Health Atlas of Maine, and give them feedback on how it goes. But also they'd be happy to share with you the food and security data and things like that. And I'd also be happy to talk with folks about some of these things too, if there's some potentially in MaineHealth project that you're interested in. They're great guys. So the final thing, and we may have time to go on to the website for this, is the fourth thing I wanted to make sure people were aware of was, it's a relatively new, it's been around a couple years, but it's run by it was created and it's administered by the United Way of New Jersey. And it's a website and multiple sets of reports, what's called ALICE. And ALICE stands for Asset Limited, Income Constrained, Employed. So it's really trying to look at this dark blue group. Essentially what they were saying was, well, you know, so many of our programs are based off of the federal poverty level, which is this 11% in Maine. In 2023, it was 11% of folks lived at or below the federal poverty level. There's a lot of limits with that. One is the federal poverty level is set for the entire continental US and doesn't take into account as accurately as Alice now can, the various differences in costs of living in various regions. The other more important thing is this group here in Alice, this is essentially, they've gone through and they've calculated for various regions, counties, and then in some cases in Maine, some of the cities, estimated the percentages of households that are living above the federal poverty level, but living below what is considered what they call a financial survival budget. In other words, they're not making enough or barely making enough to take care of the basic needs, the basic costs of needs. And if there was any kind of emergency, if they had a new diagnosis and had expensive medications that they had to take, or their car broke down, they might have to choose between food on the table, heat, rent, or so that they're not making enough. That's 44 out of 10 households in Maine, right? And it's 20. It's almost 3 times as much above the federal poverty level. This is sorry for the blurriness. It's a map that Kate Allading on my team put together, and we have in a report that we provide the senior leaders. It's called Measuring Our Vision. You can search for it on the web, the intranet at MaineHealth if you're interested. But this is on the left. This is rates of federal poverty level across the state. And then on the right, using the same range of percentages, are the percent of households within each region, census tract, who are living above, that are living below the ALICE survival budget. So it combines both those that are ALICE and those that are low in the federal poverty level. So you'll see that it gives us a whole lot more useful information, broader sets of ranges, and actionable items. I'll just point out, Cumberland County, where it's all green down here in federal poverty, for the federal poverty level, 28% of the population in Cumberland County, of the households in Cumberland County, live below the survival budget and above the federal poverty level. So it's almost 4 times higher than the rate of those that live below the federal poverty level in Cumberland County. So just very much more informative. Very quickly, what is the survival budget made up of? And I put this in here just because it's easier for you to reflect back at from the slides. You can build it in, you can on their websites, and you can even create a budget for certain areas, for certain communities. But it's the basics. It's rent, childcare, if you have children of that age, food, basic transportation. It's assuming you have a 10-year-old car, so you're not paying any car payments. Basic health care. The technology is mostly cell phone, plus cell phone for each adult, and then taxes and miscellaneous. So, but the cool thing is that they're looking not only at the costs within the local region, but they're looking at it for different compositions of households. This is for a single adult. This third column here is 2 adults and 2 children, and both children are in childcare. The annual total to be above their survival budget would be $91,000. The average median household income in Maine is far less than that, right? So it's stop sharing there, and I'm going to pop over here just very briefly. Let's see. All right, Ellen, can you see that? All right. So this is just to give you an orientation. It's unitedforalice.org. That will take you to the national page, and then you can select Maine to come down here. But there's a lot of data in here, and it's very dense. It's really, intended to be actionable items that you could talk with policymakers and community leaders and clinicians and to really take action and think about how you can do this. But just to give you a sense of some of the demographic groups, and then I'll stop and take questions. But again, this is at the household level, but it's important. What I really love about what they're doing here is they've taken into account the variability in what that composition is. And this is a rate, if you look at married with children, the vast majority are above the ALICE threshold. Single parents, single female-headed household with children, 74% are either below the federal poverty level, that dark blue, or above that and but below the survival budget. So they're, month to month, week to week, at risk any time of any kind of major issue. If you're like my daughter, who had to have brakes and tires put back on her car so it could stay registered at a tune of $1,200, that would be hard. Right? So that there's that kind of, when you're looking at that, and we can look at data over time as well. If we looked at it by age, the two big categories are those that are under 25, households led by someone under 25, and those that are over 65. But the data over time is really important here. This is the under 25. The number of households has been pretty steady. The gray is the number of households over 65. So this is just showing us that this is the number of households that are making less than they need to get by and be comfortable. So, this is just what's in the demographics. You can go in, you can look at the costs of the survival budget, and they go in more into depth in some of these kind of the details of what goes into those data. You can go into a mapping tool that will look at things across the nation. You can kind of look at and county level in Maine. And you can go in and select data by a county if you're interested in getting a specific survival budget for that county, for example. And there's other pieces in here that I encourage you to look at when you have time to really digest it. So I'm going to stop sharing and give us all enough time for people to breathe and digest all this stuff, and then happy to take questions.
It's fantastic, Tim. It's really nice having an overview. It saves a lot of time from having to go through it ourselves. What's your favorite new approaches here of these different data sets? Give us some of your thoughts, opinions.
What I love about PopHIVE and Apriqot is that they're tackling issues where they're taking multiple data sources of data and looking at things from different lenses, right? They're synthesizing data. So I definitely encourage you to kind of keep a pulse with them, particularly PopHIVE, as they're adding more stuff.
Yeah.
But a lot of you may already use the behavior risk factor surveillance survey data. We use a lot of that in our data profiles for the community health needs assessment work that's done across the state, the Maine shared CHNA. And we have county level data, but this gives us a little bit more insight. So it's exciting to see that there's 35 measures. Again, it's not everything, but the potential is there. So I really am excited about that. Encourage people to look at those issues, what's there. And maybe we can continue to encourage CDC. I think they were funded by Robert Wood Johnson for this project to do even more. I think, so I don't know that, I think if I had to pick a favorite, it would be PopHIVE and Apriqot, because I'm a data geek and I think of layers of data and synthesizing and finding, well, where's the gap in the knowledge and how can we build it?
Yeah.
But I think the places is really, I encourage people to use it because I think that can help people see patterns that they may not be when you're not as familiar with the data. So
Shannon's got a question. And feel free to raise your electronic hand, unmute, chat, whatever.
Thanks. Tim, fascinating, and thank you for sharing what you know. One of the thoughts that's crossing my mind as I listen to you is work I do in a volunteer capacity with Mid-Coast Hunger Prevention, and thinking that some of these sources might be really beneficial to not-for-profit organizations in general. And I don't know if your services include teaching folks how to use these sources. I'm just thinking, wouldn't it be cool to have some of the leaders from an organization like that have an orientation like you just offered to us?
Well, this is, by the way, this is publicly available. These grand rounds, you record them.
Okay.
So you're
maybe I can share the
link.
recording.
Yeah, absolutely. Share the recording.
And Shannon, and I would be happy to talk with folks if they have questions or even come in and work through it. In my role as a city councilor, I've certainly used Alice a lot.
When
we're talking with my fellow city councilors of why we need to deal with homeless and preventing homelessness and things like that. So happy to do that. So we can talk offline.
All right.
Yeah. And you can also, Alice is pretty straightforward too. So, I mean, Shannon, you feel send the materials. I'm just trying to protect Tim's time because I know he's busy. And we're all trying to use him for,
full disclosure, I'd be sending the materials first, but it really is. It's dense, so people will want to really kind of dig through, but they have a lot of things formatted in report fashion, so it can be handed out. So
yeah. And what sources would be best for tracking outbreaks? Alan.
Oh gosh, of those four, I would guess it's going to be PopHIVE.
Yeah.
The places is not going to help you because that's that's outdated, not recent enough data. I know PopHIVE is going to strive to have the data that they're using, and again, they're looking at medical records, they're looking at lab data, they're looking at water. I
was going to say the wastewater.
There you go.
Is a game changer. Like that has been fascinating to follow, hasn't it, Deb? I mean, you've seen, and the thing about wastewater is that you most often see it before you see the cases. So we now track infectious diseases by particularly reportable ones like measles and things like that by, somebody's seen by a healthcare provider. They are then get a lab test that's done. It confirms measles, and it's only by county because of HIPAA and the privacy rules. You can't say what town people are. But the nice thing about the wastewater data is like in some other states have done measles, you see it before you see the cases. So it's like hello, we've got measles here, even though we don't know it yet. And we've seen that with COVID and RSV and flu. We've seen the increase in wastewater before you see it in the data. And you think about it, I mean, even if you're just not even getting a lab test, you still have to go and see a provider. They have to report it. There's a lag, and that lag doesn't sound like much, but when it's a lag, a couple of days, and it's something like as contagious as measles, big deal.
Yeah, that's huge.
So yeah,
and I think too, of these four, again, it would be PopHIVE, but I would also there are really great surveillance systems that you can go on and look at data. Either from CDC and Lori, I think that's what you put in. Yes, thank you. But also at the state level. So definitely, Maine has some. The infectious disease programs have some really great data sets.
Yeah, no, that's a good point. Wait, how do you see? It's hard to predict, and this is everybody asks this question. Any kind of data, thing is that. What about AI? So it's got to be changing the landscape, right?
Yeah, I think it will. I mean, one of the things that I highlighted here are approaches that they're taking, modeling and scientific processing, mathematical systems to a new level. And I think AI can certainly help with help with that. As with anything, I think I encourage people to use it because you can go on and they may be able to say, hey, I pulled up this data from this source, or this is the rate that you get it. But definitely look at the details. So Kendall on my team did a quick search. We were testing it as a couple months ago. We were testing out AI, and she got it came back with a prevalence of diabetes or something, or maybe I don't know what it was, but I can't remember the content. But the point was the estimate she got, AI said the source was the main shared CHNA, and it was not. And it wasn't quite accurate. And it wasn't as recent as it thought. So, and you can imagine that's where if you're doing a quick search, it's going to find so much data out there. And it'd be easy for it to not find it. So, but using AI in a process to make our data tools better, I think.
And that makes sense.
I think the sky's the limit. But, be very careful. You got to look at everything. Thanks, Deb.
I agree with Deb. That's great.
So I think we only have 3 minutes left. This was a lot to digest. Thank you for sticking with us. And if you have any other questions, please feel free to follow up.
Yeah. Thank you so much. And then don't forget, Alan, what's the next date of the next? You're on mute.
The 10th of March is Dave Chosky,
the head of the Common Health Coalition.
And anyway. Elizabeth Libby put the whole schedule right there in the top of the chat. So
thank you.
Open that up. And I tried to put all the links for you, Tim, keeping up with everything. And thanks to Ken for opening up that registration for Apriqot. I just tried to do that.
And
awesome.
Thank you so much, Tim. We really appreciate your time.
You're welcome. And I'll send the slides out so they have the links as well, if you want them all in one place. So
great.
Awesome, guys. Well, have a great rest of your day. Enjoy the sunshine. Maybe more snow.
Bye.
Bye-bye.